eminent, distinguished speakers here today who have got command on the subjects, and they will inform us what it's all about, how NHS, what NHS plans are, and how we're going to serve as a community, as healthcare professionals together in the interest of patients and patients' care and patient safety. I am very grateful to all-party parliamentary group on Third World Solidarity, who is collaborating on this event. As you can see, RPS banner and all-party parliamentary group banner, and they have also in the past helped us to stage and host these events for us. The coordinator of the all-party parliamentary group, he will say a few words, and the MP Khalid Mahmood, MP, will welcome you in the Parliament, and I'll come back to say a few words about the House keeping. And I think without further ado, I'll ask the coordinator of the all-party parliamentary group, Mr. Mustapha Shah, CBE, to come and say a few words.
Ash Soni sir, thank you very much for coming, and I want to just come first because I want to explain to you what is the meeting. And Khalid Mahmood, I'm very thankful. He is a shadow minister for Europe. Right Honorable Khalid Mahmood, MP from very far. Very far. So it is very far. I always mix up because I love B is first, P is later. It is P, very, and bar later. So I'm very thankful because he was virtually asked to come and replace, so that he is also Vice Chairman of APPG on Third World Solidarity, and he's long-standing Member of Parliament. Khalid Mahmood sir, I came first because I wanted to just explain, because I have been here for past 1 hour and I have spoken to many people here, that what this meeting is about. It is about primary care home models, which is a totally new model. It needs patients to get effective service, and at some stage it will become efficient as well. So it will save money to the NHS. It is an NHS funded model where it is holistic service to the patient. They don't need appointment, they can drop in, and if I say anything wrong, Ash and Nev will correct me later on, or Zafar Khan will correct me. So Khalid Mahmood sir, in my opinion, this is a progress forward. But I think there will be some criticism on it as well, that it is a backdoor privatization. So I hope tonight we will learn more about it. Can I now once again welcome you to the Parliament, and I'm very pleased to host this meeting on behalf of all-party parliamentary group. I will learn a lot, and I hope you will learn a lot. Thank you very much for coming.
To be able to say a few words. I think you've been welcome now for the third time in the House of Parliament. We've had some horrendous cases of what goes on in nursing homes, and I think what we want to do is to move away from that. But I think the idea here, which is to allow pharmacists to be able to work in the sector and actually provide another pair of eyes to support those people in that sector. I think that's the real advantage here, is where you can have those people coming in, looking at what's going on, and to be able to support that. I think that is fundamentally important. I'm not particularly concerned about whether it's the private sector does it or the National Health Service does it, because I think it has to be an approach that can be actually suitable for the patient who needs that service. That's what's really important. As long as the person, particularly in almost difficult conditions that they're in, they need the best possible care that's important to them. They need to ensure that the medication is updated regularly, and they know. I've heard of cases where the medication hasn't changed because nobody's been able to get to that individual, and they're perhaps on medication they don't need to be on, which affects them adversely, and those sort of issues continue to happen. So I think for that reason alone, this is a fantastic idea. This is a good idea to be able to do that, but we need to follow through and ensure that we support properly the people, particularly in home care, but also allowing pharmacists to be able to diagnose prescriptions and to be able to give them. Thank you all very much for turning up here. I think it's going to be a fantastic conference. Unfortunately, I've got to get in. We've got another meetings tomorrow morning. Just to confirm, just to slightly correct Mushtaq, I'm the Shadow Minister for Europe, Russia, Central Asia, and Cyprus. So we might Shadow Minister.
MPs are very precious. They are. I struggle to go to one meeting and then attend another one, and it's nice that we have an MP's word here. And we might get some other MP, but they'll just come and look in, and they might say a few words, and then, like him, he spent more time with us. It was nice to hear nice words about pharmacy and pharmacists and pharmacy services, and I think pharmacies are primary care, one of the important part of primary care, and we like to be more involved and more recognized as primary care. And hopefully we'll probably be holding another parliamentary meeting where we might be asking the government to consider commissioning pharmacies and pharmacists, prescribing pharmacists, to lessen the weight of GPs who are already under pressure. Please welcome Dr. Chana.
Good evening, everybody. Thank you very much for that very warm introduction, Zafar and ministers. And thank you all for coming out this evening to hear us. So I'm part of a triple act. So I'm going to start by just describing a little bit about this model of care, followed by which Ash is going to talk a little bit about the role of pharmacy, particularly within the context of that. But the real star of the show is Michelle Bull, who is a member of our national primary care home faculty, who's actually implemented primary care homes in East Sussex, or Sussex specifically. So if you can just keep your attention until you get to Michelle, that would be really good. Is it okay? Are you okay with me presenting a couple of slides to you? Can you cope with that? It's late in the evening and all that kind of stuff. So sorry, just get this stuff out of the way. Okay, so let's just get this. Let's just kind of get the definitions right then. So this is called the primary care home, okay? And it's not about a care home. So I'm sorry if there's some confusion in the sort of definitions here. It's about the home of primary care within the context of a population. I'll try and explain that a little bit more, if that's okay. So are you all okay with that? Skills in that context. The second thing is about how we change the services that we provide in healthcare, particularly, so that we join them up and make it work for patients. And that's what transformation refers to. The third thing is to make sure that we do all of that so that we're as cost effective as we can be, but cost effective from the point of view of value, not just for saving money and rationing and privatisation, but actually just trying to make every pound that's invested in the NHS the most effectively used pound that we can think of, okay? And then the fourth bit, which is really important to me because of my background in workforce education, is how we put joy back at work for all of the people who work in very high-pressured environments, whether it's in the A&E department of a hospital, whether it's in a busy general practice, or whether it's a busy community pharmacy, how we really put fun back at work. So would you agree with those principles? If you do, then you'll like the primary care home. All right, so we'll come back to that in a minute. So one of the things that really exercises us in terms of improving population health outcomes is this fact that only 10% of population health outcomes are attributable to health interventions alone. All right? Only 10% of what makes a difference to the health of a population is down to the things that doctors, nurses and pharmacists do. All right? The rest are things like the broader determinants of health, such as not having a job, not having a house, not having a stable relationship with someone who loves you or who cares about you. All right? So they contribute much more to the health outcomes of a population than having GPs or pharmacists or everybody else in the system. All right? So that's not to say that we don't value what people do. It's really important that we do value that, but just remember that more health outcomes are attributable to things that are outside of health than they are to do with health alone. So the solution is how we bring together those various agencies that are involved in improving the health of a population into a place-based model of care. All right? Does that make sense? So built around a neighbourhood or a community of people. The registered list of general practice is crucial to that, but then folding in the right services that will improve the whole health of that population. And as you can see from this diagram, it's about bringing together voluntary and charitable sector organisations, local government, social care, community services, secondary care, mental health, primary care, which includes community pharmacy. All right, so when I'm talking primary care, I'm talking about where primary care actually happens rather than who is the provider of that primary care. All right? So you can see a role for yourselves within that system. So there's quite a lot of talk in the NHS at the moment about general practice at scale and it kind of needing more investment and trying to put more money into the system to try and keep people out of hospital, essentially. And here are some terms that people are using around that. You'll notice the primary care home, not a care home. The primary care home is an important part of the way people are thinking about the future of primary care provision over the next sort of 10, 15 years. So the primary care home, PCH, forgive the acronym, primary care home, has 4 very simple characteristics, all right? And then I'm going to hand over to Ash, who'll tell you a little bit more about how pharmacy fits into that. Just sort of wake him up. So the first is, the primary care home model is built around the registered list of general practice, but the registered list of general practice which is scaled up to around 30 to 50,000 people, all right? So to give you an example, in East Merton where I work, that essentially represents 4 or 5 GP practices working together as a unit, as a practice unit together to get to that level of population care. But it might also include around that unit half a dozen community pharmacies, okay, also being drawn into that kind of model of primary care. Does that make sense? And it also includes community services and mental health and diagnostic services and appropriate colleagues from secondary care working within that. The way to do that then is to take responsibility for a population-based budget at that level, to build that integrated team that we talked about, and then actually starting to think about how we improve population outcomes in the way that I said at the beginning. Does that make sense? So the left-hand side of that diagram shows the current state of primary care. Quite narrow general practice, not much provision, lots of activity going on, people wanting lots of services, and quite high referral rates into secondary care. In the primary care home model, built around a team of people looking after a population, there's still demand, but it's now managed by that primary care home unit, and there's less activity going on in secondary care. And that reduced activity is generating money that we can reinvest in the primary care sector. So this is not about changing your contracts or making you do anything you don't want to be doing. It's just reinvesting the money that's currently spent in secondary care into services that matter to people and populations. All right? So this is my last slide. Just to say that, as we said at the beginning of this is the fastest spreading new care model in England. All right? So there are currently 213 sites covering something like 17% nearly of the population of England. Very soon we'll be hitting 20%, maybe 25%, and there'll be a primary care home thing happening somewhere near you very, very soon. And so the question then is, how...
In some ways you also understand, because they've got to start to understand what their problems are and be able to identify how to deal with them. The challenge going forward is that if we're going to deliver the change that we talk about, then we need pharmacy to be involved. Interestingly, to show how significant this is going to be, the pair of us, the reason we were late was we spent the whole of this afternoon in Croydon doing a GP at scale event for them and talking about some of these issues and about the opportunities that there are to be able to re-engineer their workforce as part of what they do. So there is no doubt that across the country we are seeing a demand and a change in the way some of the modelling is happening. To the point where actually part of the tension that we currently face is that NHS England have now picked it up and called it primary care networks rather than primary care home, and there's a concern about whether that's truly bottom up or is starting to impose certain elements of what needs to happen. But from a pharmacy perspective, we have the opportunity to engage and to be part of this. It's a tough time for pharmacy, so it's very easy to go, well, you know, what am I going to do? Who's going to do it? Who's going to help me to manage this? But actually, what Nav said was, this is about how we reallocate resource as part of transformation from secondary care to primary care. That's not us doing stuff that we can't do. But there's stuff that GPs are doing that they can probably shift to us, but they don't necessarily know what it is unless we talk to them. And there's elements of what, therefore, they're able to do in terms of secondary care. But at the same time, how do we create an environment which integrates pharmacy in some ways, the integrated medicines pathway? I was talking today at various points, I've talked recently about some of the issues we face when, from a pharmacy perspective, you see someone that has an issue with a medication. And the current model tends to be, for a community pharmacy, you refer to a GP practice. If they're lucky, they'll have a GP pharmacist. But in a lot of cases, they still aren't there. Some will have access to other sources. But generally, if it's medicines related, they then refer up, because it's not their expertise. Why would it be? That refers to a hospital. Hospital will then refer to a secondary care pharmacist. Secondary care pharmacist adjusts whatever needs to be adjusted according to if it's just medication related. And that will then flow all the way back down. But we know that in a large number of cases, if a problem's been identified early enough, we can deal with it quicker by direct communication across the medicines pathway. Why can't I just talk directly to either a GP pharmacist, a care home pharmacist, an integrated care, urgent care pharmacist, an A&E pharmacist, or a secondary care pharmacist with the expertise that can support that patient's care? And how do we make that part of what we do as part of our involvement in some of this work? So again, then what we're doing is working alongside general practice and around the rest of primary care to deliver better patient outcomes and a more safe environment. It cannot be acceptable that we still live in a society where admission for patients with long-term conditions is considered okay. We need to see that as treatment failure in some shape or form. We need to resolve that as part of our patient safety profile and improving patient outcomes. So we have a responsibility to make that happen. And that is working alongside colleagues. It's not in isolation. It isn't about us working alone. Medicine optimization is not the responsibility of one clinician. It's the responsibility of all clinicians. And the better outcomes that will produce is something that we have a responsibility to help. The other area where I think we have a really key role to play is around the well-being agenda and about prevention and about how we see 4 times the number of people who go to general practice. But the vast majority of those, and I've changed the language, I always used to talk about see well people, but we see as apparently well people. Because we don't know if there's something that's going to occur, something that's underlying. We talk about people who are quitting smoking. Well, they're well, but are they going to stay well unless we intervene? We've got people who we know are walking around with high blood pressure, but aren't detected. So unless we find ways of being able to identify them and reduce the risk, we can't do something about that. Same with AF, same with a number of conditions. So from a pharmacy perspective, it's also supporting better identification of people at risk. But it's not just then going, okay, we've identified them, here you go GP, here's someone else for you to think about, because that's just going to add some workload. It's about how do we manage that as part of what we do. So identifying the right cohort of people and then thinking about how they're supported most appropriately, whether that's continuing through pharmacy or whether that's working with general practice, using nursing, using other providers, is part of what we have to do. So by being part of primary care home, we have an opportunity to be part of that integrated solution of care and be part of what we see as being outcome-driven, patient-safe environments. We want to see the UK as the safest place to take medicines. It's a key part of the strategy of the RPS. It's part of what our new vision is to be the world leader in the safe and effective use of medicines. And to put pharmacy at the forefront of healthcare. So we see a real opportunity for what we can do, but only by working collaboratively and not working competitively and looking to deliver better outcomes for the populations we serve. If you don't know where your nearest primary care home is, or whether you're in an area that has one, you need to talk to your local GPs. You need to find out whether there is something going on. Because it's only by engaging with it you'll get to know what's happening. And so the event in Croydon today that I was at, one of the conversations was, how much are they talking to the broader pharmacy market? Andrew McCoy was there, and CJ, who's the chair of the LPC. But in terms of community pharmacy, that was it. They had no other representation. So again, it's a bit of the how do they get that engagement? And it's difficult because GP practices closed for the day. The pharmacists were there providing services. But it's our opportunity to see how we integrate into that care model to deliver better outcomes. And as I say, that's not just from community pharmacists' perspective, it's our pharmacists working in GP practices, our pharmacists working in care homes. The pharmacists are working as part of CCGs because they are involved in some of the decision making that goes on. Pharmacists in secondary care because they're involved in some of that when it becomes more acute. It's all of us looking at our role across an integrated care system. And by engaging now, we have an opportunity to influence STPs and accountable care systems and integrate whatever the latest language is of STPs. We have the opportunity to contribute to the change that happens. But it will only happen if you know your role and your opportunity to engage with it and to be part of it. And part of the reason for tonight is to enable you to understand what it is. And for that purpose, in a way, you have Michelle, who can talk about the delivery part of it, so you can see what's happening and how you might be involved in that. So Nav and I get the easy job. We talk about the theory. Michelle gets the difficult job of trying to explain how it's going to work and actually to ask you the questions that help you to think about how you better engage with it. So.
In primary care homes. Michelle, please welcome.
Thank you. So I'm going to thank you for inviting me to be here. I know I'm on as other speakers on the agenda.
Have your confidence.
That's fine. I've got my contact details later on, so you should be able to find me if you need to. What I'm going to do is just give you a sort of whistle-stop tour through our primary care home, some of the things that we've done, and please do, whilst I'm talking, think about if there's ways that we've missed opportunities and any ideas, because this is the way we get things moving and taking it forward. So our primary care home is called the Healthy East Grinstead Partnership. Those of you, does anybody in here live or come from East Grinstead? Yes. Oh, okay. So I've shown it on the map because I've been aware when I've presented before, so many people haven't known where we actually are. So you can see we're south of London and we're right in the corner of West Sussex, which means that we've got a little bit of, we're surrounded by 3 other counties, which has its own challenges as well. So actually our registered population is 41,500 across 4 practices, and our population is older and most affluent than a lot of other areas and probably quite different to some in London. Those of you who may have heard of East Grinstead, we've got a history of innovation in the area for the Guinea Pig Club, which is amazing. I've got some nodding at the back, brilliant. Does anybody else know about the Guinea Pig Club? So it was Archibald McIndoe, who's the surgeon in the picture, piloted techniques, plastic surgery and burns techniques in the war with fighter pilots who've been shot down, and it's an absolutely fascinating story. So if you want to go and look at something, go and Google that. But this sort of history, the town was known as the town that didn't stare, because the patients with terrible facial burns were encouraged to get out and walk around the town and integrate with the local population. So we've done integration for quite a long time. A bit about our population: we've got higher levels of dementia that seem to be well managed. Higher levels of chlamydia rates, which we are putting down to the fact we are better at detecting than anything else. Strange anomaly of high injury rates to our under 5s, which we haven't been able to really find out why we're showing up as red, but that's there. And higher respiratory deaths amongst the elderly, and poor uptake of vaccinations. So there's quite an opportunity there immediately. This is some of the partners in our partnership. As I said, the 4 practices. I'm actually employed by the CCG to work as a locality manager, to work with the practices and to work in the primary care home. So our primary care home has very much been supported by the CCG, and I think now to say that's not necessarily the same across the board. Queen Victoria Hospital, where Archibald McIndoe worked, very much a key partner, so we're lucky we've got an acute provider. And our community trust, Sussex Community Trust as well, really, really key. And then a range of other partners across the bottom, which I'll mention as we go through. None of this is rocket science, and I'm not going to dwell on it, but basically that we know what people want. The CCG have done some engagement work, so we know what the public wants. When we very first started, we spoke to our GPs and said, right, what do you want? What's going to help, improve the services for your registered population? And again, I don't think there's any sort of standout surprises on that around just wanting to be able to get better access, help manage demand, and then picking up from what Nav said about that whole idea of joy, about making our area a desirable place to live and to work. So these were our aims that we pulled together at the beginning. We were one of 14 rapid test sites, so we've been going for just about 2 years now. Unfortunately, the whole access for GP services became a big issue very early on, so we sort of had to focus on that. All our lists were closed to new registrations or capped, so we had to work really hard around access. But actually that made us do some creative thinking around how we could redesign our care pathways, look at other workforce models. Had to get the physio bit in. It was one of the things I knew when I started straight away. It was very easy. Plus the manager at Queen Victoria, who worked as part of the partnership, he was also a physio, so we were preaching to the converted. So instead of the patient having to go to the GP, they were able to refer themselves onto physio. So we've seen over 1,000 patients go through that route, so that's freed up a significant number of appointments in primary care. I'll talk a bit about our dressings pathway. We set up a similar direct access to midwifery, and then we've also done quite a lot of work around medicines review, which I'll talk about as well. This was our dressings pathway previously. There were about 20 odd steps before the patient got their dressing. The nurse would review the patient, decide what they wanted, and then they had to fax it to the GP. And then the surgery had to move it all the way through their prescription process, which some people are nodding, so they obviously know well. The GP would eventually sign it, and then it would go on to the pharmacy. We found out that 92% of the GPs weren't satisfied with the current system and actually felt that the nurses were the dressings experts. And this picks up on what you guys have been saying around let's use people's area of expertise. And this was the sort of shock horror moment when the nurses said 85% of them had waited for over a week for dressings to arrive, and that meant quite often the patient's wound had changed, so then all those dressings were redundant and had to just be binned and started again. So our new dressings pathway, the community nurses and the tissue viability nurses order stock from a formulary, and our community pharmacy colleagues dispense those and deliver them to the nursing base, and the nurse takes them to the patient 24 hours. Bear in mind 55% in the same 2 weeks. So it's totally changed the pathway for the patient, for the nursing teams, for the GP practice, and good for our health economy. This figure of over 200 hours of nursing time, I'll let you into a secret, was actually March last year till June, July, so the same time as now this year. So right away we were able to release that amount of nursing time very quickly. And staff have also identified other areas that we could do the same thing with. I wanted to touch a bit on the work that we've done with our pharmacists for obvious reasons. So CCG supported our primary care home a lot by providing locality-based clinical pharmacists who've worked with our practices. So they've done everything from doing audits, optimising medicines. I can't say the two words that go together, but about changing prescriptions. I can't say script switch, it always comes out wrong, but I think I just managed it. And also looking at reviewing red drugs that shouldn't be being prescribed in primary care, and trying to work out how to get those. We've done some initial analysis of the figures across our CCG. So we've got 4 primary care homes in our CCG now. And we believe that we've saved in the last year about 4 million. So in our East Grinstead primary care home, that's £1 million. So when Nav talked about being able to reinvest money into the primary care home, wouldn't that be fab? We haven't quite got that bit of it sorted yet, but it's pretty impressive. I mentioned our enhanced primary care team, so we've brought together all the practitioners in our community team, our community nursing team, to form an MDT that's wrapped around our GP practices in our town. Nurses, matrons, physios and OTs, social workers, and then CPN, so really a whole team. And we focused initially on those patients who are at highest risk of admission. We've got a risk stratification tool that pulls everything that's happened to the patient for the last 2 years, how many times they've been into primary care, secondary care, how many medicines they're on, whether they're on the frailty index, and tells us who's most at risk of admission. And you'll see there we call them the 154 Club. They were the people that we really focused on. And so it's very targeted, and they developed care plans, and we shared those across all providers. So the ambulance crew were able to access them, community provider, mental health provider, and primary care. And I thought it would be worth just talking through a real life patient, because otherwise it gets a bit sort of data driven, doesn't it? So we had a patient with dementia who basically had their GP practice on 999 on speed dial, and in October 2016 the total number of calls, and that's excluding 999 and 111, was over 500 calls in October, 1 month. So our MDT, they pulled together these professionals meetings. We had the GP, the ambulance team, police, social workers, because the patient's calling the police, as well as health providers. And so they set up this sort of package of care that pulled together from all the different organisations that were involved. Really simple things like putting a whiteboard in where the carer wrote when the next carer was coming in. You know, none of it's rocket science. And basically the contingency plan said that whenever the patient called, they told her to look at the whiteboard, because that would give us some reassurance. So, and once we got the package in, you can see the number of calls went down to 56 in a month compared to the over 500 in the previous month. And 51 of those were to the Lifeline, which was set up so we could call the Lifeline. And all the future appointments are now made by the carers and the family. So it totally changed the service of that patient, but also the service for the providers working around that, you know, who are getting called these constant calls. And we've got lots of other similar examples around where social workers have been able to put respite care in a day. We run a daily huddle, so it's a patient who's literally about to deteriorate. They pull together the community team, anybody else who's needed, and work out how to keep that patient out of hospital. Like Ash's point about patient going in should be seen as a failure rather than, you know, allowing people with long-term conditions to go in. So for this highest risk of admission, we've I mentioned our meds management pharmacists. They actually link in and come to that MDT and work with the other professionals to look at what needs to be done. Is there an issue around drugs? Do we need to change? And we've also got a pharmacist who's focusing on care homes, so they're looking at polypharmacy for those patients. In East Grinstead, apparently, we've got quite a lot of care homes compared. People seem to like to retire to West Sussex, so it is very nice. So we've got polypharmacy, falls, getting involved on falls, and also doing some serious work around ordering of medicines, because we found there's this stockpiles that every time a repeat is done, they ask for everything, and also they would leave it until 5 o'clock on a Friday evening to make sure they had it for the weekend. So lots of work that's been done with care homes as well. What we're doing next with that team, and I think this is where I'm hopefully that you guys are going to come up with some examples for me around how we might be able to extend and work more. So we've managed to bring in our mental health liaison practitioners, and we've also got some Age UK voluntary sector link workers who work really closely to take people to, they want to go to the knitting club but they're too scared to go for the first time themselves, they'll take them there. They do a lot of work around benefits. I mentioned the daily huddles. We've extended the risk to the 50 to 75%, so we're looking at anybody who's over 50% risk of admission. And we're also doing that wider determinant of health that Nav mentioned. We've got the Fire and Rescue Service do their home wellbeing checks. Interestingly, they're talking about medicines to patients when they're going in and doing checks about pharmacy, so about home safety. So they're a key person that we should be linking with. And I've had this on the slide around our wellbeing team, but actually for me already there's an idea around how does our wellbeing team link in with pharmacy. So if they identify somebody that they think has got high blood pressure, should they be sending them to the community pharmacist rather than back to the GP? So food for thought. Overall for our primary care home, here's some of the things that we are now working on, which I think you will see there's a lot of these fit, and there's probably even more things that I haven't made the connection yet. We've done one health and wellbeing event that went down really well, and I think there's definitely an opportunity to extend that, and the role of community pharmacies in that could be really good. I know some of the other PCHs have done like flu events and flu tea parties and all sorts of stuff, and so that might be something we want to think about. We've trained dementia friends in our practices. We've managed to set up an in-hours access hub. Some of you may have heard that there's extended access coming from October. So we've set up an in-hours hub using some GP transformational money, working with our MIU. We looked at training a paramedic practitioner so that they can start to take on minor illnesses and minor ailments, but actually it's crying out for pharmacist involvement as well. So we need to work through how we get that up and running. Tricky questions.
I wanted to pick up on what Ash and Nav said about the collaboration versus competition between pharmacy and general practice, but it is still a problem, and I see that as a bit of a barrier in this, and I just wonder how we're going to get around that, because there's an enormous capacity in community pharmacy, and they're open 7 days a week often when surgeries are not, and how we tap into that. And I was thinking I'm in Sussex West Coastal actually, where I'm based, and our GP practices, when we did flu vaccine recently, there was no mention of going to the pharmacy for it, and they were stretched to capacity to do all this. And we must somehow get round to it. I know it's not an easy thing to deal with, but it is an intractable problem at the moment, I feel.
I think it's a really valid point. The flu vaccine.
It's not a question as such, but it's just to reinforce what Ash has said about how community pharmacy, particularly from me, how we need to change how we work, but also to tell you guys a little bit about how I'm connecting with well-being as such in my pharmacy. And it came about because I just got fed up with not knowing what was out there in my local area. So what I do now is I regularly host a lot of local voluntary organisations in my pharmacy. Usually on a Friday, it's my busiest day, so when the patients are coming in, and all it is just a table with 2 chairs outside of the waiting area. For example, Age UK, where you come in and speak to my patients as they're coming in to collect their scripts. Something as simple as that.
My question is directed at you. What type of patients can access this service? Is it, because you mentioned dementia, is it people with chronic conditions? And you said you've got physiotherapists, X-ray machines, or someone just fallen or fractured their hand, you can access that service too?
Yes, so you mentioned a lot of the services that we've got, and it's more, we're trying to signpost people to all the services so that and that's why I was just interested in the comment that was just made about how people know, a lot of it is about people knowing where to go. We've got care coordinators in our practice who do exactly that, so for non-medical stuff, they will say, right, if you need help with this, go there and do help with this, try this. If you presented with what we found, and we can't quantify it in any way, but what we found now is that if the patient fractures their hand and presents at the MIU, there's a much better network around because the practices have been working with MIU so that they know and they can just call up. And we had a great example of a Burns patient who presented at the minor injuries unit, and then actually the GP wanted to have another look at it, so called them back in. So there's just this sort of network being built up of where professionals knowing where to signpost people, but also then the next stage, and this is where some of the evidence is around people who live in that population getting more and more involved and wanting more information. We ran, when we started the self-referral, we ran a patient evening, and we had to, like 2 days before, I was running around trying to find a bigger venue, so we had so many people wanting to come on, and actually, when we got there, they didn't want information about physio, They wanted information about where they could go for physical activity, where they could go to, you know, be more healthy. So, you know, you guys have been brilliant. So it is that sort of trying to pull together all this. So I know it doesn't directly answer your question, but
I'm sure there's going to be lots of confusion around that because it took me a while to realise what it's about before today, so it's fine. I'm at the right meeting. The second point that I wanted to make is that I'm not a community pharmacist by background, and there's a new plethora of different pharmacists that are coming through. So there's pharmacists and GP practices. We're going to have care home pharmacists. We have got urgent care pharmacists. So our list is going to expand. How are you engaging with those pharmacists into this model?
Okay, sorry,
We can take 2 more questions.
Hi there. It's not really a question, it's more a comment. And actually, thank you to the lady at the back. Apologies, I didn't catch your name. And this gentleman here that sort of raised some sort of things on behalf of community pharmacists and the lady that's just spoken. Because as a community pharmacist and also having done hospital pharmacy as well, in the real world, getting out there to our GP practices is quite tricky when you're a single pharmacist based in your pharmacy. But most recently now we have healthy living pharmacies, so we do know what is the community issues for our locality. And if we take Michelle Bull's, for example, the chlamydia and I don't know, midwifery issues, not your personally, but you know, in East Grinstead, you know, in my community, I know that it is stop smoking, I know that it is sexual health, I know that it is young mums, as an example. So as a pharmacist that's keen to kind of deliver and do more, I wouldn't be here today if that wasn't the case. But I believe that the RPS, as an example, could do more for us, getting our voice out there. If I use the example that today, 500 GPs in Croydon, I live in Croydon, yeah? I wasn't aware about anything that was happening in Croydon today. And if I was made a little bit aware of something going on like that and I was available, I would 100% love to be in that community and to have that opportunity to be around that many professionals as a pharmacist and shout out about what I can deliver and what I can do. So I think that it is a two-way street here. Yes, we know who our stakeholders are. Yes, we know how to engage people, but the truth is, GPs have, what, a 10-minute slot between patients, and for me to go in there and actually go, hi, I can help you with your asthma reviews, they're not there for me to do that, but I can do so much more.
So, have you ever been to a practice meeting?
Yes, I have.
So, because that's not 10 minutes. That's normally
I 100% agree. I 100% agree because I did pad visits for care homes. I've run care homes. The reality is, it's just about the practicality of it, and that's what the lady was saying. Us getting out there, and if you talk about the GP surgery-based pharmacists, I think that's fantastic. I'd love to be able to be involved in something like that too. But them coming out to us being able to deal with the queue of patients waiting to hand in their prescriptions and then be able to talk to them too. It's the practicality to how it actually
I've done that for 30 years. I've got a pharmacy of my own in Stretton, which I did it from, and I've always done it from.
Yes.
What I do is I work sessions for the practice, and I work with my pharmacy as well. You have to think about how you remodel some of what we do as part of what we do. It can be very, and I'll challenge back in the sense that we can carry on doing what we've always done and expecting the world to change. Or we can think about how we change what we do to be able to help us to be able to deliver it. I understand completely. I know the financial challenges that I'm facing at the moment. It's horrific. You know, general practice doesn't have any idea what it's like to be in community pharmacy, right? And the financial pressures we're under. They have no idea.
I don't think any of us would be sat here if we don't want to move
absolutely.
forward.
And it's about how, the reason we're having things like this is to start to find ways to encourage that to happen. From the RPS perspective, we're absolutely out there. We've got 4 regional leads specifically appointed. We've appointed ambassadors to go out there and do some of this work. We've appointed people who are going to work with all the LPFs to be able to make that more effective. And we will do more and more of that. But at the same time, as we do, we need you to come back and make it work. Because we can't do it in isolation. It has to be all of us together. As a member of the RPS, We can support you to deliver everything we can, but you then have to think about how you make it happen. I'm a member in the same way. I'm like the president, but I'm also a member of the RPS. So it's really important for me that the RPS delivers for me personally. It's not just in that sense. So
time is running out.
This guy's good.
Thank you. I've been following PCH for a couple of years now. Yeah, unfortunately, yeah. I'm just curious about the success of this PCH model. There's lots of new models out there in the world. The hospital models, the PAC models, the larger MCP type models beyond this, and they're all trying to do similar, better outcomes, lower costs, more efficient. And you said that PCH is spreading fast. I just wondered how are you working with these other models and becoming what appears to be more a dominant model coming forward, or are you working with or against those models? And do you see any limitations to your scale rollout?
We'll work with anybody. I mean, the idea is that it's not exclusive. So it's not just the PCH way. Work with other things. But what people have said now, if you heard the integrated care systems, the initial 10, the second wave that have been anointed. The idea is a fundamental building block of an integrated care system is a primary care home style delivery unit. All right. So where people are thinking about large hospital chains and vertical integration, they're now thinking more about horizontal integration with primary care home style units, but then working maybe with an acute trust as the integrated care organisation that an ICS would be commissioning in that sense. So the sense of a population-based budget at that level and delegation of budgets down to primary care home units is very much the currency of what we're trying to do now.
Well, I mean, 90% of what happens in health is in primary care, so we have to look at how we manage primary care, not so much hospitals, in fact. And I think it's all about joining up, obviously, the health systems in primary care. They're very fragmented at the moment. We've got CCGs, we've got all the different professional committees, we've got the local authority doing public health, which is separate. We've got hospital and trust. And all these are working separately, joining up. And many patients are being transferred into the community, and they need to have closer joining up with the pharmacy and all the primary care and social care as well too. So that's where these models are going to help, really, joining up less fragmented care, and that will improve safety and cost effectiveness.
Do you think they will be much cheaper than the services presently which are provided by hospital GPs and all in a different and separate place?
I can't really answer that. It's a difficult one to say, but I mean, I think that's not really the issue. It's really ensuring safety, I think, to begin with, and more effective care, really, and improving outcomes as well. And I think that may will then provide the savings in the long term, but often, cost effectiveness often takes time to achieve, and so you can't always do that straight away. And I think this 20 billion a year that has been promised by the government, I think, is a testament to that. They have to look at how it's going to be delivered and applied, and it's all about improving outcomes and infrastructure first, and then look at how that money is going to be spent, really. And that's where primary care models, such as suggested in London, may well provide the answer.
Thank you.
Okay. Working well is it's improving the morale of the workforce, all right? Because people are feeling happier about working in a bigger team with the right skill and solutions around them. And I think, yes, it's not solving the problems of the acute sector, but that's not a bad start after a couple of years to start finding that people are feeling a little bit happier at work. Would you agree?
We can continue on the cup of tea, but
I think at least to a point, I know the subject is very interesting. I know lots of you want to ask lots of questions. The panel is here. I think they have answered, but I think we can continue. We need to vacate the room 9 o'clock, so we have got until 9 o'clock. We've got some refreshment, we can do networking. On a lighter note, I just want to release one announcement about lighter note. Michelle mentioned that in East Grinstead there are many
obviously there will be more time that the patient can spend at the pharmacist rather than the 10 minutes that the GP can give them. We'll be able to look at all the medications and perhaps they will be reducing the medications that they take, which might be causing more harm than good.
Thank you very much.
और आज की मीटिंग में देखने के माहौल में अच्छी थी डॉक्टर्स पार्लियामेंटेरियंस अदर प्रोफेशनल्स और ये